Welcome you all to our next session, which will be on heart failure. I am Dr. Mohammed Jahidul Islam, and with me, Dr. Farhana Ahmed will moderate this session. Chairpersons of this session are Professor M. Nazrul Islam, Professor Sajal Krishna Banerjee, Professor Chowdhury Meskat Ahmed, Professor M. Atahar Ali, and Professor Harisul Haque. May I request all the distinguished chairpersons to come to the dais and take their seat, please. Panelists of this session are Professor Muhammad Saiful Islam, Dr. Zulfikar Ali, Dr. Dipol Krishno Adhikary, Dr. Ariful Islam Joarder, and Dr. Rabindranath Barman. May I request all the distinguished panelists to come to the dais and take their seat, please.
Irrespective of underlying cause, heart failure generates an enormous clinical, social, and economic burden. Although some population statistics suggest there is a huge decrease in heart failure incidence in last 1 decade. The current worldwide prevalence of heart failure is 64.34 million and accounting 9.191 million year lost due to disability and $346 billion expenditure in this regard. So it has a huge impact. And early address these issues and updated knowledge of the heart failure is essential. Today we have a very eminent speaker, have a great knowledge on these aspects, Professor M. Atahar Ali sir with us. May I request Professor M. Atahar Ali sir to come to the dais and present his talk on device therapy in heart failure, finding the fit. Professor Dr. M. Atahar Ali sir.
Still good morning. Welcome everybody. যা বুঝলাম মনে হচ্ছে যে আমি বক্তা আমি সভাপতি হ্যাঁ পুরোটাই আমার এখন সবাই যদি শোনার ধৈর্য থাকে আর কি আর কেউ আছে কিনা আমি জানি না সার্জারি আর সাবজেক্টও আমার তবে আমার মনে হয় যে বিষয়টা এরকম না কারণ হচ্ছে কি যে আমি এই যে এই ইয়েটা করার আগে আমি গুগলে সার্চ দিয়েছিলাম যে আর্টিকেলস পাবলিশড অন হার্ট ফেলিওর ইন এই যে জাস্ট জুন মাসে আনবিলিভেবল কোনো মানুষের পক্ষে এটা পড়ে শেষ করা সম্ভব না শুধু একটা মাসে হার্ট ফেলিওরের জন্য যতগুলো পাবলিকেশন হয় মানে এত সো মাচ আর্টিকেল ইট ইজ টোটালি ইম্পসিবল ফর এ পারসন সো হার্ট ফেলিওর ইজ নাও এস্টাবলিশড অ্যাজ এ সাস এ কাইন্ড অফ দ্য ইম্পর্টেন্ট সাবজেক্ট এবং এর কারণ হতে পারে এই জন্যই যে আমাদের এখানে বেশ কয়েকজন আমি দেখতে পাচ্ছি যে আমাদের হার্ট ফেলিওর এক্সপার্ট আছে এবং আমি আই এম ফিলিং ভেরি মাচ প্রাউড টু বি হিয়ার বিকজ প্রফেসর হারিসুল হক মেশকাত আহমেদ চৌধুরী আমাদের বগুড়া থেকে এসছে ডক্টর শহীদুল হক উনি আমি জানি যে আমার সঙ্গে মাঝে মধ্যে আলাপও হয় হার্ট ফেলিওরের রুগীগুলো নিয়ে তারপরে আমাদের বাডেমের রেজাউল করিম ভাই দীপল অধিকারী অনেকেই আছেন যাদের হচ্ছে যে আসলে আমরা সবাই মিলে হার্ট ফেলিওরের ইয়ে করি কিন্তু নতুন কিছু বলার জন্য আমি যেটা দেখলাম যে আসলে ইট ইজ টোটাল ইম্পসিবল যে হোয়াট ইজ থিঙ্কিং দ্য সায়েন্টিস্ট হোয়াট ইজ দ্য চ্যালেঞ্জ কেন এতগুলো পাবলিকেশন আসলে টু চ্যালেঞ্জেস আর ফেসিং দ্য সায়েন্সেস টু ডেজ টু ডিল দ্য পেশেন্টস অফ দ্য হার্ট ফেলিওর পার্টিকুলারলি দ্য টু চ্যালেঞ্জেস দ্যাট ইজ দ্য রিস্ক অফ দ্য সাডেন কার্ডিয়াক ডেথ অ্যান্ড দ্য কোয়ালিটি অফ দ্য লাইফ These are the two things of a heart failure patients, and these are the reasons. There are too much publications and the articles, the sciences dealing with these two subjects, how to reduce the sudden cardiac death and how to improve the quality of life in a heart failure patient. That's because, you know, the heart failure patient repeated hospitalization, limited activities, physical burden, social burden, economic burden, lots of the things, psychological burden, inputs some bad impression on the heart failure patient, and these are the reasons the heart failure patients are suffering a lot, the family suffers a lot. So these are the two reasons the science is dealing with the heart failure patients how to do to reduce the sudden cardiac death and the quality of the life. And the reason is that one of the most important pathology in a heart failure patient is the dyssynchrony. You know, it is a big subject, talked much subject, about the dyssynchrony, what is the dyssynchrony, what is the impact. But finally, it is one of the most important factor why the heart failure patients are refractory at a time, does not respond to the medical treatment. And this is one of the main mechanism for refractoriness of the heart failure patient, that is the dysynchrony. And dysynchrony does not happen to all the patients, as because some of the other factors, as because the dysynchrony again produces the reduced ejection fraction, and the reduced ejection fraction is responsible for the sudden cardiac death. And these factors again related with the LV scar. It is not related to the ischemic or non-ischemic, whatever may be the etiology. But at the long term, if the patient survives, there will be fibrosis of the scar, and finally the dilatation. So dysynchrony, reduced ejection fraction, LV scar, and the dilatation are the main pathological hallmarks of a failed heart that gives the pathological features in the heart failure patient. And ultimately, all these factors in a coordinate or discoordinated fashion, two things they produce. One is the persistently high afterload of a heart failure patient, persistently high. The afterload, it is already a failed heart, and this failed heart always faces the persistently high afterload. And this is again increases the internal stress. Internal stress produces the increased LV pressure, and ultimately thinning of the LV wall, reduction of the LV mass, and alteration of the geometry. All these factors are interrelated. No single factor is responsible for the heart failure patient's morbidity. All these factors are interrelated. And one of the again factor, Dr. Ahsan Habib already told, there is the LV dilatation, secondary mitral regurgitation, again puts some burden to the failed heart. So it is the persistently high afterload and the mitral valve dilatation, that is mitral real dilatation that produces the mitral regurgitation. Two are the main important factors that gives some abnormal property to the heart, so that the heart progressively goes toward the failure. So these are the reasons, that is to improve the quality of life and to reduce the sudden cardiac death. These are the challenges the sciences are facing, and this is the region. There are too much papers on this subject. And to deal this subject, always drugs is the first. We always teach our students, written in the text, that is a drug first. That is the heart failure patient. Even I will discuss about the device therapy, but in the guidelines it is stated, no device therapy is recommended without prior, that is guideline directed medical treatment. So drug is the first. But very important to see, since 1970s, over the past 50 years, only 4 drugs now available at our hand that can reduce the mortality of the patients. There are too many drugs that is used in the heart failure patient. That is some of the drugs are the background drug. These are particularly related to the symptomatic treatment. There is no input to the mortality, that is the mortality benefit. Only 4 drugs, that is spironolactone, ARNI, beta blocker, and SGLT2 inhibitors. Only these 4 drugs, those are called the Fantastic Four. They have proved their efficacy, that they can reduce the mortality, also can improve the quality. The other drugs, that is the diuretics, digoxin, what you say, this can only give the symptomatic benefit to the patient, no input to the mortality benefit. So this is not easy. That is despite the several studies, innovations, determination, over the last 50 years, the sciences has produced only 4 drugs. And the 4 drugs can give the mortality benefit not too much. You see, the mortality benefit of the AC inhibitor is 16%, beta blocker is 34%, that is the spironolactone 30%, and the receptor blocker is 17%. None of the drug has crossed the 50%. And although the benefits are additive, not like that, 16 plus 34 plus 30 plus 17, not like that. There gives some additive effects of these drugs. If we can able to add the drugs, there will be some addition of the benefits, not that it is the simple addition. So there will be some addition. So despite all these productions, all these innovations, even with this Fantastic Four, still 50% of the patient die in 5 years from the heart failure. So much so disease, and this is the reason everybody knows, we tell that is heart failure is more dangerous than the cancer. That is still there, even with this Fantastic Four. There are challenges, that is the 50% of the patient die in, that is the 5 years. And this is the reason where the drugs fail. When there is the limited role of the drug, there comes the role of the devices. So there are some devices you see. The aim of the objectives of the device is also to deal the sudden cardiac death and the quality of life. And these are the types of devices you can see in the slides. The devices, the devices can be classified for the acute heart failure as well as the chronic heart failure. There are some electrical devices like the ICD, CRT, His bundle pacing, you know. And there are some mechanical devices, that is the impeller, ECMO, and LVAD. And some valvular diseases, that is the mitral valving. These are all the devices. All the devices are FDA approved, are being used, but not all the patients get access to these kinds of the devices. Not all the patients gives their criteria to have these kinds of the devices, and there is a limited role. 2 of these devices, among all the devices, only 2 of the devices are being used worldwide, and the patients are getting access to the devices. And ESC guideline 2022 has summarized all the patients of heart failure just on the basis of the 2 factors, that is the ejection fraction and the ECG, only these 2 things. And the other guideline also included the NOSA class, but the ESC guideline also considered, that is the ejection fraction, and they have set the cut marks of the ejection fraction at the 35. They have not included in the study that is the more than 35. That is, we will discuss only the patient who has got the ejection fraction less than 35, and we will divide the patients depending on the QRS duration. Less than 130, straight away the patient is selected for the ICD, and more than 130, selected for the CRT-D, and in between 130, we don't know what to do. That depends on the patient's quality. So, ESC guideline clearly states there are devices, but the devices has got also some limited role. They cannot satisfy all these patients. You can classify this patient depending on these ECG groups, and you will get only 2 kinds of the patient, less than 130 ICD, more than 130 CRT-D. But what to do? Those will not fit for this patient. So this is the, again, these are the challenges for the devices therapy. And this is one of the example you see. This is the ICD that is considered as the emergency room in the chest. And since, again, you please look at, since 1990 till 2015, over the 25 years, there has been 12 big trials, 40,000 patients are enrolled, and summary of the result is that from all these 12 trials, that is ICD has proved 40% reduction of the sudden cardiac death. This is the ability of the ICD. This has proved, and there is no further need of the study to prove the efficacy of the ICD. ICD has been already proved that it has got the ability to reduce the sudden cardiac death as much as 44%. And in summary, for the reduction of the sudden cardiac death, either by device or by the drugs, we have got only 2 things, the Fantastic Four or ICD or the CRT-D, nothing more. Fantastic Four or the CRT-D. And the other drugs in these 12 trials, amiodarone, flecainide, disopyramide, these 3 drugs has been trialed, but none of the drugs proved their efficacy to reduce the sudden cardiac death. Even they have increased, I will show later on. So we have got only the Fantastic Four and the ICD or the CRT-D for the reduction of the sudden cardiac death. And this is the ICD trials. You please look at the trial. This is the region I am showing this trial, you see. None of the trials after 2000, that is by 2000, it has been proved ICD has got this quality, that is they can reduce the sudden cardiac death. And all these trials, 1997, 2000, 2000, 1990, that is all the trials has been finished by 2000. Since 2000 till date, there has been other studies, but no need. All the guidelines since then till to date, ESC or the AHA guidelines are based on this trial. That is the AVID trial, CID trial, CAST trial, or for the primary prevention, the MEDI trial, mass trial. These are the trials. These have founded their foundations for the development of the guidelines. So there is no need that the ICD has got this quality. This is proved. The ICD can, but ICD cannot. We have got the feelings that ICD has the quality. The patient who has got the ICD, he will never die. No, you please look. That is, ICD has got also the limited capability. It can reduce sudden cardiac death, not the mortality, not all cause mortality, only the arrhythmic death, 44%. So this is the ability of the ICD. And these are the trials, and the trials are finished by 2000. And again, despite these trials, beautifully written guidelines, not only in Bangladesh, it is worldwide. Physicians believe ICD cannot do all the things. Still they are using, we are using the anti-arrhythmic drugs. And you please look at the tables: lignocaine, mexiletine, flecainide, beta blocker, amidon, sotalol, calcium channel blockers. These are the drugs in different ways have been used in the previous trials and consider the mortality or the risk of the sudden cardiac death. And please see, the lignocaine has the neutral effect, mexiletine neutral effect, flecainide has been stopped in a study. Rather, it increased the sudden cardiac death. Beta blocker, this is one of the drug, can reduce both the mortality and the sudden cardiac death. But amiodarone, again, what we cannot believe, that is the amiodarone does not have the mortality benefit. It can only reduce the arrhythmic death, not the total mortality. You please try to understand, only the arrhythmic death, not the total mortality. Sotalol has the neutral effect, and the calcium channel blocker is also neutral effect. So the drugs, only very limited drug, beta blocker and amidon has got some benefit. None of the drugs either neutral or detrimental. So this is the that is the facts about the drugs. But despite all these facts, still the use of the antiarrhythmic drugs in a susceptible patient, even more than the devices, these are being used. But if at all we have to select the drugs, this is the guideline we can select on the basis of the sum of the side effects. These are the drugs. So sudden cardiac death, this is the summary. That is the summary of the selection criteria of the ICD for the heart failure patient. You see, that is all the criteria when the ejection fraction is less than 30. How much important the ejection fraction is? There is no need of other criteria. The single most only ejection fraction is sufficient. Nothing to see. What is the class of the patient? Whether the patient has got the arrest or not, nothing to see. The guideline states less than ejection fraction, class 1 criteria, you have to put the ICD. We are not doing, but this is written in the guideline. But if the ejection fraction is 30, less than 35%, that is more, 5% more, then we have to consider that is the class 1, that is anyways a class 1 is not selected. And if the ejection fraction, if you increase further 5%, that is 40%, then you need to prove the non-sustainability. So this is the simple criteria for selection of the patient, either less than 30 or 35 or 40, depending upon the ejection fraction criteria, we can select the patient for the ICD. And for selection of the criteria, that is the ICD, we have to think, this is very much important, not always, but at least at this stage, Honorable Chairperson, that is for the ICD selection, we must consider the contraindication. We have to see the indication as well as the contraindication. We are actually interested about the patient's VT, cardiac arrest, but we have to see also the contraindication, that is the post-MI less than 40%, that is the non-ischemic cardiomyopathy less than 30, that is less than 3 months, and NY a class 4, insistent VT, or the reversible ischemia. These are that is the contraindication, that is before selecting the patient. We have to see whether there is any factors or not like this. Then these are the patients are not selected for the patient. And within 40 days post-MI, what to do? This is the burning questions for the that is from the beginning. What to do within the 40 days? These are the 2 studies. They are very limited, no big trials. Only 2 small scale studies, that is the dynamic studies and the IRIS investigation studies. The dynamic studies finished in 2004, and the IRIS studies finished in 2013. They have selected the patient after MI within 40 days who has got the arrhythmia, and proved there is no arrhythmic benefit, that is the reduction of the mortality from the arrhythmia, rather increase of the mortality from total mortality. So this is the region, that is the post-MI patient within 40 days are not selected for the ICD patient, and who has got the 35 UFC, that is the ASC guideline selected, that is the 35. So what to do? The patient who has got the more than 35%, answer is unknown. We don't know what to do and what will the benefit. That is, guideline has not selected this patient. They have selected only the patient who has got that. So the guideline, there is no study, so I have no answer. So again, the QRS duration, honorable chairperson, I am the only speaker. If the time is short, if it is, just let me know, I will stop. And for the another groups of the patient, I have already stated, that is the ejection fraction less than 35%, and QRS duration is more than 130. I have already told ejection fraction less than 35, QRS duration less than 130. And now, ejection fraction less than 35, QRS duration 130 or more. These are the groups of the patient we can select. That is for the CRT D or CRT P. And the main objective of these kinds of the device, resynchronization. And this resynchronization ultimately gives rise to the MR reduction, reverse remodeling, and this benefit is achieved only when there will be such kind of the ECG. You see, this patient had got late bundle branch block, but after resynchronization, like this implantation of the CRT-D or CRT-P, this is the ECG that looks like almost normal, but this is not always possible. This is not easy. Every person will not show like this. There will be some limitation, and this is the region they have selected this criteria. And why not less than 130? There are now too many studies. There are three studies you see, the Rethink trial, ECO-CRT trial, and that is LASER trial. These three small scale studies, they have considered the patients less than 130, but ejection fraction less than 35%, and none of the studies proved benefit from the CRT. And this is the region. The guidelines, particularly the ESC guideline, has excluded this criteria. That is nothing to do. These groups of the patient, although the patient's quality of life is disturbed. And from this above slide, this clumsy side you see, what we follow the ACC or the ESC guideline, there are some marginal differences for the selection criteria. Class 1, Class 2, and Class 2B, I will not discuss this criteria. But what is seen, that is in all these criteria, the Class 1 criteria is same. Class 1 criteria is same, ESC or ACC. Class 1 criteria is same. But there will be some difference in the Class 2A and 2B criteria. I will not discuss this. The Class 1 criteria in both the guidelines is same. What is that? That is the LBB morphology, QRS duration equal to or more than 150. This is consistently right. And these groups of the patient, almost sure, they will get some benefits from the CRT therapy. But not all the patient, because as much as 30% of the patient may show, that is, they do not show their response to the CRT therapy. Who are those? These are some extension criteria. We always, most of the times, overlook this criteria and give some, that is the patient's luck is bad, the echo is not good, you are not taking medicine regularly, but not this. We have got some role. The physician also got some role for the proper selection of the patient. And these are the some roles. I have got some idea. Honorable Chairperson, Professor Meskat Chowdhury, he has sent many, good number of the patients. He is one of the person whom I respect. He has got this capability. He sees this extended criteria for showing this is not only the guidelines told, it is the ejection fraction of the QRS duration, But we have to see as a clinician for selecting the patient and telling the patient, that is the discussing with the patient, will be benefit or not, to discuss with the families. There are some limitations. All the patients not equally benefited. Some 50%, some 60%, some 90%. And some of the patients may show the super responder. Not all the patients. Who are those? And these are some criteria. This is very much important. That is the global scar burden. This is very much important. That can be we can predictions from the ECG, also from the ISCO, and also the scar location. It is the lateral of the scar. The inferior scar is we cannot overlook. But if the lateral of the scar, as because the CS lead will be on the lateral wall. If the scar on the lateral wall, the QRS duration will not be reduced. The patient will not be reduced. So it is the global scar, scar burden, scar location, mitral regurgitation, all the factors in addition to the QRS duration and LV function determines the which patient will determine not. And right bundle branch block, this is not uncommon. Right bundle branch block is also very common, but all the right bundle branches are not excluded. For the careful analysis of the right bundle branch block, it is told that RBB masking LBB, some of the right bundle branch block, some additional criteria, in addition to the classic criteria, that gives this patient has got some other conduction defects. What do you want to mean? Is it the only right bundle branch block or some of the other conduction defects that can produce the dysynchrony? That is the main factor. Yes, that is slur in the R in one or AVL, if right bundle branch block, but there is slurring in the ROF in the one or AVL, that determines this patient has got some conduction defect in the left bundle also. And left axis deviation or atypical right bundle branch block. So, not all the right bundle branch blocks in general are not excluded. The right bundle branch block giving some unmasking features of the left bundle branch block are the criteria that may show the benefit. So, if we classify all the patients less than 35 on the basis of QRS duration, these are the QRS duration, this clumsy slide show published here, and summary of this slide is that QRS duration more than 120, LBB 34%, RBB 22%, and QRS duration less than 120, sinus rhythm 44%. So we cannot satisfy all the patient considering the ECG and the echo. There will be some of the patient, those are not suitable candidate neither for the ICD nor for the CRTD. What to do? Over the last 2 decades, starting from 2000 till to date, there has been shifting of another interest of the device therapy from the classic CRTT or CRTP toward the His bundle pacing. That is pacing of the His bundle. This is one of the challenging part for dealing the patients with the heart failure nowadays, and the His bundle pacing is not for all. Again, this is for some group of the patient. That is the patient who will give some abnormal heart failure from the already implanted pacemaker, that is pacemaker induced cardiomyopathy, or CRT non-responder, or some other criteria that exclude the patient for having the CRT or ICD. So these are the groups of the patient for whom the His bundle pacing is nowadays is being advised. And this is the 2018 ACC AHA guidelines, class 2A or class 2B indication for the implantation of the His bundle pacing. This is already included in the guideline. This is also ESC guideline, class 1 even with the level of evidence C, and class 2A indication for the implantation of the His bundle pacing when the patient will fulfill this criteria. So there are some good effects, some beneficial effects of the His bundle pacing, and this is the region. The His bundle pacing is now included in the guidelines. And finally, non-LBB ECG, LBB ECG not responding to the device therapy, or CRT responder now are the classic candidates for the His bundle pacing. And this is the His bundle pacing. This is one of my patient, the single chamber VVI pacemaker, the lead implanted at the His bundle area, And this is, you can see the beautiful ECG. What is the objective? Just giving rise, that is the some kinds of the ECG that looks like almost the physiological ECG. These are the two ECGs, the above ECG, the RBB, the lower ECG now normalized to the normal. This is not my slide, this is downloaded from the ESC guideline. Again, this is another ECG. Here you can see the selective versus the non-selective, that is the His bundle pacing, not only limited to the His bundle area, can be done also to the downwards, that is the late bundle branch area. And this is again the ECG that is depending on the site of the His bundle pacing, either the His bundle area or the lower area, that is, it can be classified as the selective or the non-selective His bundle pacing. And again, the His bundle pacing has been included for the heart failure management. And this is the region. The His bundle pacing has been compared with the biventricular pacing and giving some the almost parallel or equal benefit, not inferior to the classic biventricular pacing. That is His bundle pacing not inferior to the classic CRTD or CRTP pacing. And this is again one of our patient. Here we have done the late bundle branch pacing. That is the QRS is, you can compare, you can memorize the previous ECG. The QRS duration is little more wider. This is the late bundle branch pacing, but this is easier. The learning curve is less here. So we can do that, we can treat, but this is better than the other kinds of the His bundle pacing. And another groups of the patient who has got the combined atrioventricular block and the heart failure. And this is the subgroups of the patient where the despite the ejection fraction 35 to 60, that is 36 to 60, there is recommendation for the implantation of the CRTP or CRTD in case of the heart failure with AV block. These are the only groups of the patient. All the patients, ejection fraction less than 35, but here you can increase the selection criteria in between 35 up to 50% of the ejection fraction. More than 50%, it is the physician's choice whether he will do the His bundle pacing or the conventional right bundle branch pacing. And this is also again challenge for the heart failure patient with the atrial fibrillation. There are some of the trials, small trials, what to do with the atrial fibrillation patient. These are the 4 trials. All the trials has recommended. There is 2 trials has showed without the AV node ablation, the heart failure with the atrial fibrillation patient may be benefited. Companion trial says no. PAVE trial says yes. If the patient gets benefit, you have to do the AV nodal junction. So this is another, that is the classic heart failure patient. There are 2 subgroups. One is heart failure with the AV block, and another is heart failure with the ejection fraction. And what to do with these groups of the patient? There is heart failure with the AV block or the heart failure with the that is the atrial fibrillation. Another recommendation is that hot CRT, his optimized CRT, that is His bundle optimized CRT, that is CRT will be done optimizing the His bundle area, combination of that is the one kind of the hybrid treatment you see. There is His bundle pacing also done and the CRT is also done. This is called the hot CRT, and inclusion criteria is failed His bundle pacing, even when the His bundle pacing cannot show the consistent benefit, His pacing or the failed CRT or non-responder. These are the groups of the patient. Those can be selected again for the hot CRT. And this is the one of the example of the hot CRT. The right ventricular lead, instead of putting to the His bundle area, that is the instead of putting to the septal area or the RV wall, has been put to the His bundle area. This is called the hot CRT. That is putting of the RV lead to the His bundle area or the late bundle branch area. This is called the hot CRT. Nowadays, hot CRT, one of the important device kind of the treatment, that is when the heart failure can be dealt. And this is one of the results of the heart failure studies. And here you can see heart failure study has shown consistently a better result for the heart failure patient. And finally, again, this slide shows that these are the devices. And one of the devices I have not talked, that is the LVAD. The upcoming lecture will be on this, that is the LVAD. This is one of the, again, this is talk. And this is thanks. And dear participants and the honorable distinguished participants from these thanks, you can see the word thanks, capital and the small combination. There is a message. Despite all the things, innovation of the drugs and devices, there is more number of the patient, huge number of the patient, of the heart failure patient, they are beyond our reach. They are not getting the treatment, not getting the good result. Even having the CRT or ICD, 30% of the patients are not getting their optimum result. So science is struggling with the heart failure patient, how to improve the quality of the life and reduce the sudden cardiac death. And this is the reason huge number of the patients every day being published and uploaded in the Google. Thank you very much for your patient sharing.
Thank you, sir, for your excellent presentation as always. It is very informative, and thank you, sir, for introducing us hot CRT and his bundle pacing. We have very learned panel and a great audience in front of us, and the floor is now open for discussion. If any question, our speaker will answer.
Sir, I have a question. I have a patient who have undergone CRT-D in our institute just 3 years back. He has a history of post-MI patients with standing in LED 5 years back in Ibrahim Cardiac Center, and he has also diabetic mellitus. A patient's ejection fraction was just 30%, and it was LBB morphology, and it was more than 160 milliseconds. Tushar is here, I think, that patient. So, sir, after implantation of CRT-D, patient was doing well for the last 2 years, but for the last 6 months, he again developed frequent shortness of breath, and his ejection fraction going down to 25 to even to 22%. And surprisingly, his ECG shows that reappearance of LBB morphology. And we have done his ECG, chest X-ray, and echocardiography. His lead position was in all right position. So what is the explanation, sir?
আচ্ছা, তো এগুলোই হচ্ছে আসলে ডিভাইস থেরাপির লিমিটেশন, যে আমাদের একটা ধারণা আছে যে ডিভাইস দিলেই বোধহয় সব কিছু হয়ে গেল। আসলে তা না, দিজ আর দ্য লিমিটেশন অফ দ্য ডিভাইস থেরাপি। মেবি যে এক্সপ্লেনেশন হতে পারে যে তার এলবি থ্রেশহোল্ড বেড়ে গেছে, অথবা লিড পজিশনটা ঠিকমতো হয় নাই, অথবা লিড ডিসঅ্যালাউন্সমেন্ট হয়েছে, অথবা সবচাইতে ইম্পর্টেন্ট যেটা এভরিথিং ইজ ওকে বাট দেয়ার ইজ প্রোগ্রেসিভ, দ্য প্যাথোলজি প্রোগ্রেশন, দ্যাট ইজ প্যাথোলজিক্যাল প্রোগ্রেশন। ওই জায়গাটা হয়তো ফাইব্রোসিস হয়ে গেছে, ওই জায়গাটা হয়তো স্কার হয়ে গেছে, মানে ফার্দার মোর কন্ডাকশন সিস্টেমের ডিজিজটা হচ্ছে। অ্যান্ড দিজ আর দ্য রিজন, যে বললাম না যে গ্লোবাল স্কার, লোকেশন অফ দ্য স্কার, দিজ আর দ্য ভেরি মাচ ইম্পর্টেন্ট ফ্যাক্টর যে কোন পেশেন্টটা করবে। অ্যান্ড দিজ আর দ্য লিমিটেশন অফ দ্য ডিভাইস থেরাপি। এবং আমরা যে এই যে কিছুক্ষণ আগে যে আমি যে ফিজিওলজিক্যাল বডি, যাদের কন্ডাকশন সিস্টেম ডাউনওয়ার্ডস ফ্রম দ্য হিজ বান্ডেল টু দ্য লেট বান্ডেল, রাইট বান্ডেল, এমনকি পার্কিনসন সিস্টেমে যদি এক্সটেন্সিভ ডিজিজ হয়, ইভেন উইদাউট দ্য ফিজিওলজিক্যাল পেসিস দে ডাজ নট শো রিডাকশন অফ দ্য কিউআরএস ডিউরেশন, সম্ভব না। তার পার্কিনসন সিস্টেমে ডিজিজ আছে, ওর তো কিউআরএস নেরো হবে না। So thank you very much, Vijay. Tomar question,
sir. I have a question, sir. How you confirm the position of the lead in the his bundle? Is it with the help of the EP or only the fluoroscopic guidance?
Fluoroscopy plus EP. EP has got very important role. That is fluoroscopically we can select. That is the RAO position.
Yes, sir.
There is the hilum to the apex, imaginary line. You can select the area. This is the his bundle area. This is the late bundle area. So this for the location of the his bundle. But for the EP is very much important for the optimum ECG criteria. That is at the beginning of the starting of the screwing, there will be some ECG morphology. When the screwing, you are screwing and screwing, there will be changes of the QRS morphology, and finally when the screw is done, there will be that is continuous ECG monitoring, both the fluoroscopy and the ECG. These two are essential for the optimum positioning and
Sir, you placed the EP catheter during that period of PPM implantation, EP catheter?
Sorry? Oh, EP catheter, yes. EP catheter is for the his bundle location, nothing else. Only for the his bundle location. You have to see, this is the his bundle area. This is the only role of the EP. That is the his bundle area. That is, the companies are being trying, that is without EP system, this is possible.
Sir, one important information you have mentioned that we have to wait for 3 months for non-ischemic cardiomyopathy. This is very important. I have gone through a patient of sister of a government service. He was a patient, cardiac arrest survivor patient, and developed LBBB. Ejection fraction was 35%. implanted CRT-D about 5 years back. Then she came to me that his battery is not working, whether he should replace the device or not. I gone through all the papers and redo the echocardiography. There is no wall motion abnormality. Ejection fraction is normal, and she has no symptom. So probably that was a cardiac, viral myocarditis or any other things, or maybe a super responder. I don't know. And the patient is not from well-to-do family. So I, after consultation with the Professor Rafiq sir, I advised not to replace that battery, and she is doing well without CRT-D support in the last 6 months. What is your comment, sir?
আমার মতে খুবই একটা ভালো ইনফরমেশন দিল। আমার জানা মতে আমার কাছে এরকম প্রায় 4টা রোগী আছে, এরা ইন্ডিয়া এবং সিঙ্গাপুরে লাগানো। ওরা এখন প্রায় আসে যে স্যার আমার ডিভাইসটা খোলা যায় কিনা। তো যাই হোক, এটা আসলে এটা দ্যাট ইজ এ লিগাল ইস্যু, এটা চাইলে খুলে দেওয়া যাবে না, কিন্তু মানে পেশেন্টের বেনিফিটটা এরকম হয়েছে না, তো ওই রকমই আমার মনে হয় যে সমস্যা হয়েছে, গেছে, লাগাই দিছে, কিন্তু অপটিমাম ডিউরেশন, প্রপার মেডিকেল ম্যানেজমেন্ট, দিস ইজ ভেরি মাচ ইম্পর্টেন্ট। এখন আমি দেখি যে আমি যে পেশেন্টকে বলতাম যে ডিভাইস লাগবে, 2-4 মাস ওয়েট করলে দেখা যায় তাদের অনেকেরই কিন্তু লাগে না, অনেকেরই লাগে না। এখন গুড নাম্বার অফ দ্য পেশেন্ট, এই ফ্যান্টাস্টিক 4-এ কিন্তু আসলে ফ্যান্টাস্টিক রেজাল্ট, আসলে অনেকের লাগে না।
Sir, I have a question regarding drug management of heart failure therapy. 2022 ACC heart failure guideline, they mentioned that variciguat class 2A indication, and some whispering is there in next ESC guideline it may came as a class 1, like 4 fantastic will be replaced by 5 fantastic, and pharma market also vibrating with this drug. Sir, what is your comment regarding this drug, variciguat? Yeah.
কোনটা?
Variciguat, sir. Only আমাদের মার্কেটে আসছে।
আচ্ছা, ফ্যান্টাস্টিক 4 ওই স্লাইডে কিন্তু ভেরিসিগুয়াট আছে, নট অ্যাজ এ মোর্টালিটি রিডিউসার। That is included, that the patient will, that is a stabilized patient, compensated patient, when will be decompensated. That drug has got some role. Still now, there is no data that this drug can reduce the mortality. The mortality benefit, only fantastic 4. Still there is no mortality benefit credit to the vericiguat. It can have symptomatic benefit still today. But that is included in the...
Sir, variciguat is the 5th drug being recommended, going to be recommended probably. Variciguat সম্পর্কে যে স্টাডিটা হয়েছে, that could not prove the mortality benefit. That only showed that selected group of patients had the benefit in terms of hospital readmission. কিন্তু to me, আমার কাছে একটা জিনিস অ্যাট্রাক্টিভ মনে হয়, why these people has brought this variciguat so early in the country. অন্যান্য ওষুধ, অনেক প্রয়োজনীয় ওষুধ আসা হয় না, কিন্তু এই ওষুধটা তাড়াতাড়ি নিয়ে আসছে কেন? Are this drug going to be useful to us? একটা জিনিস কিন্তু variciguat সম্পর্কে আমার কাছে অ্যাট্রাক্টিভ লেগেছে, সেটা হলো যে ইট ক্যান বি ইউজ ইন আ পেশেন্ট উইথ রেনাল ফেলিওর। যেহেতু মাল্টিডিসিপ্লিন হসপিটালে আমি কাজ করি, আমি জানি যে মেনি অ্যাবাউট পেশেন্ট আর হ্যাভিং রেনাল ফেলিওর অ্যান্ড দি হার্ট ফেলিওর। সেই পেশেন্টগুলোতে কিন্তু আপনার ফ্যান্টাস্টিক গ্রুপের 3টা ড্রাগই দেওয়া যায় না বিটা ব্লকার ছাড়া। variciguat সেখানে কিন্তু একটা খুব অ্যাট্রাক্টিভ অপশন হইতে পারে। অ্যান্ড ইউ হ্যাভ রাইটলি মেনশন দ্য 2022 ACC AHA guideline has promoted it as 2A drug.
Thank you, sir, for your nice comment.
About variciguat, আমার চিন্তা একটু অন্যরকম। It is the only drug which acts intracellularly and it acts through the second messenger. Okay? আদারওয়াইজ আমরা এসি ইনহিবিটর, এআরবি, বিটা ব্লকার যাই ব্যবহার করি না কেন, বিটা ব্লকার গিয়ে কাজ করে হরমোনের উপরে, অ্যাড্রেনালের উপরে কাজ করে কমায় ম্যাট্রিক্সের থিকনেস বাড়ায়। এসি ইনহিবিটর, এআরবি যেটা আতার ভাই দেখালেন একটু আগে, 17% এবং 16% ডেথ কমায়, এরাও কাজ করে ম্যাট্রিক্সের উপরে, কিন্তু ইন্টারসেলুলারে কাজ করার মতো একটাই ওষুধ এখানে আমাদের কাছে আছে ভেরিসিগুয়াট। ফলে আমি খুব আশাবাদী পরবর্তী সময় লং টার্মে ভেরিসিগুয়াট জাতীয় ওষুধ আরও আসা দরকার। কারণ হার্ট ফেলিওর কেন হয় আমরা যদি চিন্তা করি, যে একটু আগে যেটা বলছিল বিপ্লব, যে তার একজন পেশেন্ট আইসিডি লাগানোর পরে দিয়ে ইমপ্রুভ করছেন, আরও খারাপ হচ্ছে, যেটা আতার ভাই পরবর্তী সময় বললেন হয়তো অন্য কোনো ফ্যাক্টর থাকতে পারে। প্রথম ফ্যাক্টর যে দ্বারা যে হার্ট ফেলিওর ডেভেলপ করলো, তার ট্রিগারিং ফ্যাক্টরটা কি? 50% ইস্কেমিক, 50% নন ইস্কেমিক কজ প্রথমে ভাগ করলাম। করার পরে ভাবলাম যে যারা সেপ্টিসিমের জন্য হলো ওরা এক সময় ঠিকঠাক হয়ে যাবে ইভেনচুয়ালি, যারা ভালো হলো না, হ্যাঁ তারা কি এটা একদিকে রাখি, আরেক দিক যারা ইস্কিমিক গ্রুপ এভাবে ক্লিন কার্ড বলা হয়েছে যে ইস্কিমিক কজে যারা হার্ট ফেলিয়ার রুগী আসে তাদের সার্ভাইভাল রেট বেটার, তাহলে ইস্কিমিক জন্য ডিভাইস দিলাম। যারা নন ইস্কিমিক সেপ্টিসিমিয়ার রুগী বা অন্য কোনো কারণে, যেমন কালকেও HIV পজিটিভ পেলাম, এনজিওগ্রাম করতে গিয়ে আমরা করতে পারলাম না, এই জাতীয় সেকেন্ডারি কজে যাদের হার্ট ফেলিয়ার ডেভেলপ করে সেসব ক্ষেত্রে আমাদের একটু চিন্তাভাবনা করার ব্যাপার আছে। তাহলে আমরা যদি চিন্তা করি যে বাইরে দিয়ে ম্যাট্রিক্স এবং ইন্টারসেলুলার স্পেসে যে হার্ট ফেলিয়ারের জন্য ফাইব্রোসিসের ট্রিগারিং ফ্যাক্টর, এদেরকে ঠেকানোর জন্য কিছু ওষুধ আমাদের প্রয়োজন, এক। নাম্বার টু, ইন্টারসেলুলারলি যারা সেলুলার সাইটোপ্লাজমিক বিহেভিয়ার চেঞ্জ করতে পারে ওখানে কিছু ওষুধ আমাদের দরকার। তাহলে যতই ডিভাইস দিই না কেন, ডিভাইস দিয়ে আমরা ঠেকাতে পারবো কিন্তু প্রগ্রেশন ঠেকাতে পারবো না। কারণ হার্ট ফেলিয়ার গোড়ায় যদি চলে যায় আমরা ডেফিনিশনে, ইটস এ ক্রনিক প্রগ্রেসিভ ডিসঅর্ডার, এই তিনটা টার্ম বলতে হবে, ক্রনিক এবং প্রগ্রেসিভ। তাহলে প্রগ্রেশন ঠেকাতে গেলে আমার জিনে কাজ করতে হবে, এই জন্য রিজেনারেটিভ মেডিসিন একটু কাজ করছে, কিন্তু তার চেয়ে ভালো হবে যেমন এখন রিসার্চ মানে রিসেন্ট রিসার্চটা ফোকাস হচ্ছে যে জেনেটিক লাইনে কি করা যায়, কোন কোন হরমোন এবং ইন্টারলিউকান এইখানে দায়ী। করোনা আসার পরে হার্ট ফেলিয়ার স্পেশালিস্টদের মাথায় এটা বেশি কাজ করছে, কারণ লক্ষ্য করছে করোনা এসে ইন্টারলিউকানসগুলি লাঙে ফাইব্রোসিস করছে। আমরা যে ধরে নিই সেই অনেক আগে আমরা পড়তাম যে ইন্টারলিউকানসগুলি ইন্টারস্টিশিয়াল স্পেসে গিয়ে কাজ করে, মেট্রিক্সগুলিকে হার্ডেনিং করে, হয়তোবা ওইসব ক্ষেত্রে ড্রাগগুলি এখানে আসতে হবে। ফলে আমার মনে হয় ভেরিসিগুয়ারটা এ ব্যাপারে বোধহয় প্রমিজিং হতে পারে। আমরা ভবিষ্যতের দিকে তাকাই, ওষুধের অপেক্ষা আছি।
Sir, I have a question. So far we know the EF less than 35% is the one of the most important
actually we
predictor
are running
for arrhythmia, that
short
is
of time.
20%. Sir, besides this, nowadays scar burden, and especially scar is the needles for the ventricular arrhythmic death, especially VT. So in NICM patient where non-ischemic cardiomyopathy, what is the rationality to put ICD in this case? And another thing, before putting ICD, do you have explored all the etiology of NICM? Especially in India, there is study of, it has the tubercular myocarditis is underexplored. They found that. And sarcoidosis, cardiac sarcoidosis also cause of dilated cardiomyopathy, which may be treated by steroid and other immunosuppressive agents. And I want to know that in nowadays cardiac MRI can detect the scar, especially non-responder case, we can easily detect the lateral scar also. So we are not focusing on the scar area detection and its burden and other etiology of NICM before putting ICD, because it's a very expensive device, I think.
থ্যাংক ইউ অজয়। মেশকাত ভাই বলে চিনি কেনা হচ্ছে ডাক্তার অজয় সিলেট। ডাক্তার অজয় ও হচ্ছে কার্ডিয়াক এমআরআইতে স্পেশালাইজেশন করা আছে কার্ডিয়াক এমআরআইতে, যেখানে ওই কোশ্চেনটা করছে ডক্টর অজয় খুবই ভালো আর কি, এবং আমাদের কার্ডিয়াক এমআরআইতে আমাদের খুবই হেল্প করে। আমরা প্রেজেন্টেশন আছে না, তাই থ্যাংক ইউ অজয়। ও কোশ্চেনটা যেটা করছে, ইয়েস দিস ইজ ট্রু, এবং যেটা আমি বললাম যে আসলে এক্সটেন্ডেড ক্রাইটেরিয়া এইটা এখনও পর্যন্ত ফিজিশিয়ানের হাতে, দ্যাট হ্যাজ নট বিন ইনক্লুডেড ইন দ্য গাইডলাইন, বাট গ্রাজুয়ালি দ্য ইম্পর্টেন্স অফ দিস, দ্যাট ইজ এ স্কার লোকেশন ডিটারমিনেশন, এটা এত ইম্পর্টেন্স হচ্ছে যে ভবিষ্যতে ওই যে যেরকম ইসিজি ইকোর মতো কার্ডিয়াক এমআরআইও যে রুটিন গাইডলাইনে আসবে না, আই ডোন্ট নো, আসতে পারে। কারণ হচ্ছে দেখা যাবে যে অপটিমাম বেনিফিটের জন্য বললাম না, এই সেভের পেশেন্ট এখন কিন্তু আবার কিছু কিছু জায়গাতে আছে যে সব কোনো কিছুই নাই, এই সেম আছে কিন্তু স্কার বার্ডেন বেশি, তাহলে লাগাও আইসিডি। তো এই যে কথাগুলো এখন একটা স্পোরাডিক্যালি হচ্ছে, কিন্তু গাইডলাইনে আসলে তো তখন সবাই করবে। তো আমার মনে হয় যে থ্যাংক ইউ ভেরি মাচ ফর ইউর থিঙ্কিং, এটা আসলেই নাওয়াডেজ
latest development for the non-responder, is it? I think it is a good news for the non-responder of CRT. তাই তো বলছেন আপনি?
জি 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 জি
Okay, that's fine. But what is your present condition in this country with dealing the non-responder?
সরি,
বর্তমানে আপনি non-responder পেশেন্ট আপনি কি করতেছেন?
কোনটার জন্য? ও নন রেসপন্ড হয়েছে, আচ্ছা।
আপনি কিভাবে এই পেশেন্টগুলো হ্যান্ডেলিং করতেছেন আর কি?
ইয়েস, মানে যারা নন রেসপন্ডার ফেল্ড, যেমন মানে তার অপটিমাম করোনারি সিএস নাই, টেকনিক্যালি ফেল্ড, অথবা করার পরেও যারা রেসপন্ড করে নাই, অথবা যাদের অপটিমাম কিউআরএস ডিউরেশনটা ন্যারোইং হয় নাই, যেমন 150 কিউআরএস ডিউরেশন, আমার টার্গেট হচ্ছে অ্যাটলিস্ট 30% রিডাকশান, ফিজিওলজিক্যাল না হোক অ্যাটলিস্ট 30%, এরা যদি দিজ আর দ্য গ্রুপস অফ দ্য পেশেন্ট যাদেরকে হট সিআরটি, ইভেন দেয়ার ইজ এ ট্রানজিশন দ্যাট ইজ শিফটিং, আমরা যেরকম রেডিয়াল করতে গিয়ে ফিমোরাল করি, এরকম কিন্তু এখন অনেক ফিজিশিয়ানস আর ডুইং দিস ওয়ার্ল্ড ওয়াইড, যে তারা সিআরটিডি করতে গিয়ে ফেল মারলো তো ওই পেশেন্টের হট করে দিয়ে আসলো আর কি, অ্যান্ড দিজ আর বিং ইনক্লুডেড ইন দ্য স্টাডি। তো এখন কিন্তু বেশিরভাগ এইভাবেই হচ্ছে যে এটা ফেল করলে ওটা করে আসতেছে আর কি, এরকম হচ্ছে। সো আসলে স্টিল নাও হিজ বান্ডেল পেসিং, হট সিআরটি, দেয়ার আর লিমিটেড স্কেল স্টাডিজ, আমি যেটা দেখালাম অনলি দেয়ার আর ফিউ স্টাডিজ যেখানে 44টা পেশেন্টের এরকম হয়েছে। আমার মনে হয় যে এটা আসলে সময় নেবে, একটু টাইম উইল সে তে হোয়াট ইজ দ্য, যেমন এক সময় আমরা বলতাম যে ইয়েস আরভি পেসিং না করে সেপ্টাল পেসিং করো হয়ে যাবে সব, এখন দেখা যাচ্ছে সেপ্টাল পেসিং করো না হিজ বান্ডেল পেসিং করো হয়ে যাবে সব। তো এই আসলে একটা টাইম লাগবে, দিস ইজ দ্য বিউটি অফ দ্য সায়েন্স, আসলে টাইম উইল সে দ্য অ্যান্সার। তো দিজ আর দ্য পেশেন্টস যাদেরকে ফেল্ড অথবা টেকনিক্যালি পসিবল না, দিজ আর বিং ইনক্লুডেড ইন দ্য হট সিআরটি। থ্যাংক ইউ চেয়ারম্যান স্যার।
হিজ পেসিংটা অনেক ডিফিকাল্ট, ইজ ইট ট্রু? মানে সিআরটি করাটা অতটা টেকনিক্যালি ডিমান্ডিং না, কিন্তু হিজটা করা আসলে খুব ডিফিকাল্ট, এমন কি?
ইয়েস, হিজ বান্ডেল পেসিংয়ের কিন্তু অনেকগুলো লিমিটেশন আছে, যেমন স্টিল নাও হিজ বান্ডেল পেসিং করতে গেলে ইপি সিস্টেম থাকা লাগবে, বাট দ্য ট্রাইং যে উইদাউট ইপি কীভাবে করা যায়, এটা হচ্ছে একটা। দুই হচ্ছে যে মানে হিজ বান্ডেল পেসিং করে ওই ইসিজিটা, কারণ আমার টার্গেট হচ্ছে যে ফিজিওলজিক্যাল ইসিজি তৈরি করা, তো ফিজিওলজিক্যাল ইসিজি তৈরি করাটা ইজি না, ওটা মানে আমরা যেরকম আরভি পেসিং এক জায়গাতে আর ঠিক পেলাম, প্যারামিটার ঠিক পেলাম, আমরা স্ক্রু করে দিলাম, এটা কিন্তু স্ক্রু করো আবার খোলো, স্ক্রু করো আবার খোলো, স্ক্রু করো আবার খোলো, এখানে কিন্তু ফ্লুরোস্কোপিক লোডও বেশি পড়ে, টাইমও বেশি লাগে, এবং অপারেটরদের কিন্তু লার্নিং কার্ভও খুব লম্বা লাগে। সুতরাং এটা রিয়েলি মানে দিস ইজ ওয়ান অফ দ্য লিমিটেশন অফ দ্য হিজ বান্ডেল পেসিং, এটা লাগে কিন্তু, বাট করে ফেলতে পারলে আসলে দেখা যাচ্ছে যে ভেরি গুড।
As we are running short of time, we may invite our next speaker, please.
Sir, yes, sir. Thank you, sir, for your valuable comments. We are running short of time. There is time constraint and there is Juma prayer. So we move to our next lecture on end-stage heart failure and role of mechanical assist device. And this will be taken by Dr. Arif Ahmed Mohiuddin. May I request you, please?
Honorable Chairpersons, respected panelists and learned audience, good afternoon. I am Dr. Arif Ahmed Mohiuddin from United Hospital, Dhaka. On behalf of Dr. Jahangir Kabir sir, our Chief Cardiac Surgeon, is presenting in this session. Due to some illness, Jahangir Kabir sir is unable to attend this prestigious occasion, and I am going to present. My topics of presentation is end-stage heart failure and role of mechanical assist device. I have nothing to disclose. So, as we all know, heart failure is a progressive clinical syndrome with an estimated global prevalence of 26 million. Over the past 2 decades, the pharmacological therapy has a huge progress to treat the patient with heart failure with reduced ejection fraction, but the patients with advanced refractory heart failure, medical therapy often may alone not be inadequate and associated with high mortality in the absence of advanced therapies like ventricular assist device and heart transplantation. Substantial progress in the field of mechanical circulatory support has expanded the treatment options for those patients with end-stage heart failure. The short-term MCS devices are primarily used for high-risk percutaneous cardiac procedure and cardiogenic shock and post-cardiac arrest, while durable mechanical assist device, that is LVAD, are increasingly utilized for the patients with end-stage heart failure. So why VAD is used in end-stage heart failure? As we all know, in end-stage heart failure, the patients become very poor quality of life with a significant reduction in the patients suffer from low output syndrome, the failing heart, unable to pump the adequate amount of blood to maintain the perfusion pressure. This ventricular assist device helps this patient to pump into the body, and which helps them to buy some time. They can be help them to allow to buy some time for transplantation. And even if those patients who are contraindicated for heart transplantation, They can be used as a destination therapy to improve the quality of life and also the quantity of life, that is the prolongation of life, which would have been impossible without the support of the ventricular assist device. And the 2021 ESC guidelines also indicated the use of VADs in this situation. So, before choosing a patient to implant a ventricular assist device, and we have to evaluate the patient thoroughly, both medically and psychosocial aspect. Why psychosocial aspect? Because as this device is a very costly device, and patient needs to be very much educated to handle this device. Once implanted into the body to support your heart, this device has to be maintained for a prolonged period. And in order to have a good outcome, psychosocial aspect is very important. Whether the patient has the self-care ability to maintain the that device. He can, whether he will be able to maintain the anticoagulation profile and taking care of the driveline, which need to take care for till the device remain within the body. And he has to always maintain a follow-up with his heart failure physician and take some investigation and come to the hospital. And the support of the caregiver is also very important, because once the device is implanted into the body, the surrounding caregiver role has a very significant role, because this device has some function in emergency situation. If the caregiver are not educated enough to handle any complication, it will be disastrous. So psychosocial aspect is also very important. And for medical evaluation, we need to evaluate both cardiac and non-cardiac side. For cardiac evaluation, once the patient with advanced heart failure are referred to an advanced heart failure therapy center, they are evaluated with various things for cardiac evaluation. Like the conventional NYHA and AHA staging of A to D sometimes has some limitation to evaluate what is the worst stage of the heart failure. And that's why Intermax profile, that is the inter-registry for mechanical assisted circulatory support profile, was created to identify those patients who actually need heart failure device in stage 4, stage D or NYHA class 4. And this profile help us to identify the patient who are at the highest risk of mortality and morbidity, and to whom we need to implant the device within shortest possible time. As in this graph as shown, when the patient in Intermax profile 1, they are the worst group of patients with advanced heart failure with critical cardiogenic shock and the declining their end organ perfusion. And this patient needs to implant within hours. And profile 2 are the progressive declining phase, where the patient are on despite inotropic support, the condition is not improving, and end organ perfusion is also declining. So these two classes of people needs to be implanted with LVAD within hours to days for taking decision. And the profile 3 and 4, those are inotrop dependent, whether we can stop it or win from them. They are having, can be implanted LVAD with elective procedure, and we can buy some time for weeks. And Intermax 5, 6, 7 are the more stable group of people where we can evaluate them and where we can buy some time to whether we will put the LVAD or not. And other than the symptomatic treatment, for cardiac evaluation, we have to also look out for the RV function, because once the LVAD is put into the heart, the left side of the heart resulting in appropriate function, sometimes the right side of the heart fail to perform accordingly. And once the right RV dysfunction develop, this patient have a poor outcome in the long run. So in preoperative evaluation, we need to evaluate RV function with echo and cardiac cath. And we also look into the valvular status of the heart, because once the LVAD is put into the heart, there is outflow tract is given into the aorta. And If aortic valve, it has aortic stenosis, it is good, not a problem. But once there is a aortic regurgitation, there is every chance of going from the pump to the aorta and coming back into the LV, which will worsen the and decline the performance of the LVAD. And also we have to check the mitral valve, whether it has stenosis or regurgitation. If there is mitral regurgitation, it will not, it is good because it will improve once the LVAD start to function. But if there is mitral stenosis, there will be inadequate amount of blood will be received in the LVAD, so we have to address that problem during the implantation of the LVAD. And for non-cardiac evaluation, that is the other organ perfusion needs to be evaluated during that period, because lung function, renal function and hepatic function needs to be addressed during the time to see the operability and the outcome of the performance. And also, is there any presence of any infection or coagulopathy is there or not. So once the clinician dealing with the patient with advanced heart failure, this menomic gives us a very clear-cut evidence when we need to refer this patient into the advanced heart failure therapy center, where they will be evaluated to decide regarding implantation of the LVAD, that is, I need help. And optimum timing of the referral is very important, because the attending clinician who are practicing this dealing with this patient, if they are very too late to refer this patient, they are become the Intermax class 1 or 2, and we do not get enough time to support this patient, and the worsening of the outcome is there. And once we put an LVAD, every device has some limitation, and we have to deal with some challenges. Like once the LVAD is put, there is a chance of bleeding, there is infection, there is thromboembolic manifestation, stroke, pump failure. These are what are the obstacles we need to overcome during the period. But with the evolution of LVAD, and the current third generation of left ventricular assist device, that is HeartMate 3, the currently only available LVAD in the world, has overcome these challenges a lot. Because in this third generation pump, they use fully magnetically levitated technology, which created a frictionless surface within the pump, and there is very minimum chance of thromboembolic manifestation in this group of valve. So once Churchill says, however beautiful the strategy, you should occasionally look for the result. And being the clinician who would like to refer this patient for LVAD implantation, they would like to see the result, whether it is good, this current generation valve or not. Initially, the rematch trial first in 2001 gives us the confidence that the use of assist device have the superior performance over drug therapy in case of advanced heart failure. And the recently published 1 year back, the Momentum 3 trial, which compared the second generation assist device with the third generation assist device in terms of survival and event-free survival, because people these days not only think about survival. When we prolong the life, they want to know whether the prolongation will be event-free or not. And when this study was done, they shows that there is as you can see from this slide, from second to third generation slide, at the end of 2 years, there is a gap between the event-free survival. That is 75% of the patients survive at the end of 2 years. And among these patients, this HeartMate 3 valve is associated with need for pump replacement or survival free of disabling stroke, reoperation to replace or remove a malfunctioning valve. And there was an extended trial of the Momentum 3 was done, which evaluate the real-world scenario when there was a long-term outcome of the Momentum 3 pivotal trial, and another continued access protocol study was done of 2,200 patients who were HeartMate 3 was implanted. And they shows in their study that similar rate of survival among the continuous group and the pivotal group, and 2-year survival is almost 80% in HeartMate 3 group. So once this sort of device gives up support and patient benefited from this, we think that we should also give us our patient to benefit from this device. And considering this total benefit, we also offer one of our patient to implant device who was in end-stage heart failure, and I am going to sharing some of our experience with this patient. She was a 42-year-old lady, diabetic, dyslipidemia, arrived in our OPD on a wheelchair. She was on breathlessness on talking and unable to walk, and had a recent history of repeated hospitalization with acute LVF. She was diagnosed case of DCM, related heart failure with optimized GDMT in 2016 in outside the country, and underwent a MRI compatible SICD device was implanted to prevent sudden cardiac death. But no CAG was done during that period. But later on in different countries like Singapore, Malaysia, and Istanbul, Turkey, there was multiple CAG was done, and there was multiple PCI in the LAD, OM, and distal RCA was done. But despite this all support, the patient has an increasing symptom of heart failure, sleepless night, and multiple hospitalization in the recent last 6 months. So upon arrival, we evaluate the patient regarding offering her to implant an NVED device. The echo shows LVF was 22%, LVIDD 68, and there was a several global hypokinesia with diastolic regurgitation abnormality of grade 3. RVF was 25 to 30% with severe MR due to non-coaptation of mitral valve with normal aortic valve, and PSP of 70 millimeter mercury. And our CAG also done, which reveals patent stent with mild proximal RCA narrowing, and right heart catheterization was also done, and it shows moderate pulmonary hypertension with raised LV filling pressure. PVR was 3.2 Woods unit. And we conclude with the patient of ICM related stage D heart failure, switching between Intermex 4 and 5 on optimized GDMT scheduled for ventricular assist device. So being the current generation, third generation HeartMate 3, we offered her a LVAD system as a bridge to transplant therapy. And in order to establish this sort of advanced heart failure therapy to the patient with end-stage heart failure, we try to, it was a long process where we attended various seminars, workshops, and build as a team to offer this sort of patient like assist device or heart transplantation. As heart transplantation is not at this moment very difficult to find the donor, we emphasis more on the assist device, and we procure various instruments to combat during the perioperative and postoperative scenario. Like we have procured Sentimec ECMO and nitric oxide to handle during the postoperative RV dysfunction, continuous cardiac output monitor, and lots of things have been arranged at a time to go for the next level. And this is the operative video of our patient, where as you can see, patient is, our anesthesiologists are preparing for and the conventional standard median sternotomy has been, is going on, and aortic and two-stage venous cannulation done. And we are preparing the HeartMate 3 to be implanted. As patient is on pump beating, the apex is elevated to identify the implantation site. There is a marking, and the apical cuff of the HeartMate 3 is And now we are swinging the apical cuff into the apex of the heart. It can be swing first and then coring, or you can also core first and then swing. Now we are applying bio glue, and the apical cuff is now attached and stabbing in the apex of the heart, and coning will be gone. During coning, we have to, their TE guidance has to be there to identify, and the septal wall needs to be addressed whether it doesn't injure the septal wall. So the coding is going on. Coring done, and a portion of the myocardium of the apex is cut. And now we are connecting the HeartMate 3 with the heart. This is the outflow graft of the LVAD were attached, and there is outflow graft. This dearing is going on in the HeartMate 3, and now the HeartMate 3 is attached with the heart. And this is the outflow tract. The pump is going on, and there is a drive line. We are creating a subcutaneous plane to come out the drive line from the HeartMate 3, and it will be connected to the charging port. And the outflow tract is now measured and cut, and a side biting clamp in the aorta is placed, and we anastomosis the outflow tract with the aorta. And after weaning, this is the 6th postoperative day when the patient first walked with carrying her battery with a bag in side poke, and this is the 12th postoperative day when the patient, during his staying in the cabin, she was practicing to going for home, climbing up the stairs, and preparing for discharge and going back to home. And she was discharged uneventfully, and after 1 week of discharge, she was able to attend a program arranged by the United Hospital to meet the press and shared her experience during this journey of heart failure. And this smiling face tells the story. The patient who was having so much symptomatic for the last 6 months is currently able to, within a month after the surgery, she was able to come into the in a program with a very smiling face and express her experience with us, and she was very happy with the current status of her condition, and with a very limitation previously, but after the implantation of the LVAD, she returned back to her normal activity with very few limitations, get her life back, feel better, and she was able to enjoy her life. So with this experience, we can say that the current generation, third generation left ventricular assist devices are the very durable assist device, are very much feasible for the patient who are able to implant and can have a good, healthy life after the implantation. So I would like to conclude that it is not how much you do, but how much love you put in doing. Thank you all for your patient sharing.
Thank you, Dr. Ahmed, for your excellent and brilliant presentation. And I'd like to take privilege to congratulate Dr. Jahangir Kabir sir and his team to introduce LVAD to Bangladesh. Congratulations.
Thank you.
I have a question, please. You showed us that the patient is doing well now, but it is a bridging therapy, right?
Definitely,
so,
we offered her as a bridge to transplant, as we have not able to convince, procure any donor heart yet. In our hospital, we are trying to convince whenever we find to any brain death patient, and the law which is passed in the parliament in 2018 also helps our scenario improve. And we are looking for it, and we hope we will be able to do the heart transplantation in the near future if the donor we find. Because in our heart failure clinic, Smiling Heart at the United Hospital, there is more than thousands of patients who are under the medical management, and a lot of these patients, mostly young, are died within a few years without receiving any sort of this advanced therapies. And we are trying to motivational programs, providing some leaflet and everything to encourage people for donation, and hopefully in near future we will be able to do the transplant in this type of patient.
How long we can keep the patient on LVAD?
There is even with second generation LVAD, there is a scenario for more than 10 years of survival, and the Momentum 3 and the extended Momentum 3 trial, which shows the compare the outcome of the third generation of the LVAD, shows that even in the patient with a destination therapy, who were put in as a destination therapy 2 hours out at the end of the 2 years, the event with survival is still 80%. So it is a very good outcome. And when the patient is put on LVAD with as a indication of bridge to transplant, those patients are survival at 2 years is near about more than 85%. So long data is still coming, as it is as recommended by FDA for destination therapy only in the 2017 and as a bridge to transplant and destination therapy. And we will hope in the coming future 5 years survival result also will come. And few centers with the 5 years result is near about 60% of the patient are still survived with this assist device.
Thank you. As we are running short of time and Juma prayer and lunch break is ahead, so I am inviting a few comments from our respected panel. Dr. Rabindranath Barman, Dr. Dipol Krishno Adhikary.
Sir,
thank you.
Sorry, sir, just to add something more. Actually, thank you for inviting us to present a case in this brilliant session. I'm Dr. Rafi, sir, also from United Hospital. We both are associate consultants there, and we really being grateful to have this opportunity to present this case here in this beautiful environment. Sir, actually, we need to establish transplant, that is heart transplant, in this part of the world, because this LVAD, though it's an excellent thing to serve the heart failure patient, but this is not a treatment for all. Sir, we need heart failure clinics. I know that our cardiologists are doing the excellent things, but there are a lot of heart failure patients in this part of the land and in the subcontinent also. Indians, Pakistanis, even the Sri Lankans are way ahead of us in the field of surgery regarding heart failure treatment. So, sir, this LVAD might be actually a milestone, but we need to collaborate and we need to work together to reach out to the middle class or the poor even to help them with the heart failure. Thank you, sir.
Thank you, the organizers, for inviting me as panelist here. I'm very much grateful and honored to be in this dais with these legends in front of me. When I was invited, I thought that আমি একটু বাংলায় বলি যে আমি তো আসলে হংস মাছে বক যথা, কারণ আমি তো ইন্টারভেনশন থেকে অনেক দিনই দূরে। তো যখন আমাকে আমন্ত্রণ জানানো হলো, দেখলাম যে এমন একটা বিষয় যেটা হচ্ছে সমস্ত কার্ডিওলজিস্টদের বলতে পারি একটা ব্রেড অ্যান্ড বাটার, বিকজ দিস ইজ দ্য ফাইনাল কমন ডেস্টিনেশন অফ অল হার্ট ডিজিজেস। ইভেন আমরা এখানে যারা আছি আমরা অনেকেই দেখব যে আমরা স্টেজ এ হার্ট ফেলিওরের অলরেডি ঢুকে গেছি। সো দিস ইজ এ সাবজেক্ট where we have to work in hand with all our colleagues like cardiac surgeons, EP specialists, imaging specialists, and from our two great lectures, especially from Professor Atahar Ali, we have come to know that we have many more things to do for the heart failure patients besides our medical therapies we are offering by the world physicians and cardiologists. এবং এখানে এই যেটা আমি একটু বলতে চাই যে the all shoes not will fit for everybody. এক জুতো যেমন সবার পায়ে খাটবে না, তেমনি সব থেরাপি কিন্তু সব পেশেন্টের জন্য অ্যাপ্লিকেবল না, অ্যান্ড দ্য থেরাপি মাস্ট বি ইন্ডিভিজুয়ালাইজড। এবং আমরা দেখেছি যে সিআরটি, সিআরটিপি, সিআরটিডি, আইসিডি সবগুলোই কিন্তু একটা অ্যাডভান্সড ডিভাইস এবং বেশ কস্টলি, এবং অনেক অ্যাস্ট্রিনজেন্ট ক্রাইটেরিয়া আমরা সিক করার পরেও দেখা যাচ্ছে যে 1/3 পেশেন্ট নন রেসপন্ডার হয়ে যাচ্ছে রিগার্ডিং দ্য সিআরটিডি। তো এখন আমাদের সেই ভাবনা চিন্তাগুলো করতে হবে যে আরও কিছু ক্রাইটেরিয়া আমাদের ফিক্স করা উচিত কিনা, যেমন আমরা কিছুটা আলোচনা করেছি যে কার্ডিয়াক এমআরআই, এমপিআই এবং ভায়াবিলিটি দেখার জন্য আদার যে মডালিটিস আছে, এমনকি ইপি স্টাডিও কি আমাদের করা দরকার আছে কি না, যে আমরা যখন এই এক্সপেন্সিভ ডিভাইসগুলো লাগাবো সেগুলো যেন নন রেসপন্ডার বেশি না হয়, সেগুলোর দিকে খেয়াল রেখে আমাদের কাজ করতে হবে। এবং সবশেষে জাহাঙ্গীর কবির স্যারের প্রতি আমাদের হ্যাটস অফ, উনি আমাদেরকে একটা অন্য উচ্চতায় নিয়ে গেছেন আমাদের বাংলাদেশি ফিজিশিয়ানস অ্যান্ড সার্জনদের। তো তার প্রতি গভীর কৃতজ্ঞতা এবং শ্রদ্ধা জানাই, এবং আমরা আশাবাদী যে খুব অদূর ভবিষ্যতে আমরা হার্ট ট্রান্সপ্লান্টের মতো টেকনোলজি আমার এই দেশেই পাবো। এবং আমি সবাইকে আরও অভিনন্দন জানাচ্ছি যে আমি তো গত 2 দিন এই হলটাতেই বসি বিশেষত, কারণ আমি সাধারণত দুর্বল জায়গাগুলোতে বেশি। তো এখানে আজকে আমার যেটা ভালো লাগলো, যেখানে যেমন অনেক লেজেন্ড ইন্টারভেনশনিস্ট ছিলেন, সঙ্গে দর্শক সংখ্যাও কিন্তু অনেক ছিল, হয়তো জুম্মা প্রেয়ারের জন্য অনেকে লিভ করেছেন। আমার কাছে এই জিনিসটা খুব এক্সাইটিং লেগেছে। এবং আমার পাশে আমার ডাইনে যে 2জন লেজেন্ড আছেন, আমি একটু বলতে চাই 2 মিনিট বা 1 মিনিট। সেটি হচ্ছে যে একজন হচ্ছেন বঙ্গবন্ধু শেখ মুজিব মেডিকেল বিশ্ববিদ্যালয়ের হার্ট ফেলিওর ডিভিশনের চিফ প্রফেসর চৌধুরী মেশকাত আহমেদ স্যার, আরেকজন বাংলাদেশ হার্ট ফেলিওর যে সোসাইটি তার সাধারণ সম্পাদক কবি অধ্যাপক হারিসুল হক। আমি 2জনকেই আমার অন্তঃস্থল থেকে গভীর শ্রদ্ধা জানাচ্ছি, কারণ এই হার্ট ফেলিওরকে নিয়ে আমাদের অনেক স্বপ্ন, অনেক কাজ আমাদের করতে হবে, এবং এই 2জন প্রবাদ প্রতিম মানুষকে নিয়ে আমরা এগিয়ে যেতে চাই। আমরা আপনাদের অবগতির জন্য কিছুটা জানাই যে আমরা অলরেডি একটা স্পেশালাইজড হার্ট ফেলিওর ক্লিনিক অতি সম্প্রতি চালু করেছি। আমাদের দেশে আরও কয়েকটা ইনস্টিটিউট এভাবে কাজ করছেন। আমরা যদি সবাই হাতে হাত মিলিয়ে একে অপরের সঙ্গে মিলে কাজ করতে পারি, তাহলে হয়তো আমাদের এই যে হতভাগ্য হার্ট ফেলিওর পেশেন্টগুলো, তাদের একটু আশার আলো আমরা দেখাতে পারবো, তারা যেন আর একটু বেটার কোয়ালিটি অফ লাইফ এনজয় করতে পারে। এই আশাবাদ ব্যক্ত রেখে সবাইকে আবারও ধন্যবাদ জানিয়ে আমি আমার এই সংক্ষিপ্ত বক্তব্য এখানে শেষ করছি। ধন্যবাদ।
Thank you, sir, for your valuable comments. Now, comments from the chairpersons. First, I would like to request Professor Harisul Haque, sir, for your comment, please.
Thank you very much. Heart failure session, it was a very fantastic, though only 2 lectures were presented. Everything was fantastic. One was delivered by Professor Atahar Ali and other from the United Hospital. Our another steps towards the moon, that was the successive treatment with the left ventricular assisted device. Thank you very much. Thank you all.
Now it is time to hand over the crest to our speaker. I'd like to invite Dr. Arif Ahmed to come on the dais to receive his memento. Now I am requesting Professor Meskat sir to give a conclusion remark of this session.
Thank you very much for having me here. I would not have speak a lot. কিন্তু এখানে ডক্টর মোমেন এবং ডক্টর নূর আলম থাকার জন্য আমি একটি কথা বলার চেষ্টা করতেছি। সেটা হলো, we had a wonderful session. Why we do have scientific session. We really want to hear from a person who are conversant with all these things. We had Dr. Atahar, and we really liked his lecture because he is the person যিনি জীবন থেকে যে অভিজ্ঞতা সেখান থেকে উনি কথা বলেন। আমরা যখন একটা কনফারেন্সে আসি, আমরা তো ইউটিউব থেকে শুনতেই পাই। তো সেটা শোনার সুযোগ আজকে আমাদের হলো, দ্য ফার্স্ট পার্সন এক্সপেরিয়েন্স। অ্যান্ড অফ সেম নোট, আমরা জানি যে ইউনাইটেড হসপিটাল যার তারা LVAD করেছে, সেটার অভিজ্ঞতা আমাদের শোনার সৌভাগ্য হলো। কিন্তু যে জন্য আই ওয়ান্ট টু স্পিক আ লিটল, নূর আলম এবং মোমেন এখানে আছেন, সেটা হলো যে উই হ্যাভ স্টার্টেড লট ডুইং অন ক্রনিক হার্ট ফেইলিওর। ড্রাগ থেরাপির কথা আমরা বলেছি, ডিভাইস থেরাপির কথা বলেছি, কিন্তু একটা জিনিস আমার কাছে খুব বেদনাদায়ক মনে হয়, সেটা হলো যে অ্যাকিউট হার্ট ফেইলিওরের পেশেন্টদের ডিভাইস যেগুলো দেওয়ার। কারণ আপনারা মোমেন এবং নূর আলম আপনারা দুইজনেই ইন্টারভেনশন করেন এবং স্ট্রাকচারাল হার্ট ডিজিজ নিয়েও কাজ করেন। অ্যাকিউট হার্ট ফেইলিওর পেশেন্টদের জন্য ডিভাইস ইজ এসেনশিয়াল টু সাম পেশেন্ট, যাদেরকে যদি আমরা ব্রিজ করতে পারি তারা কিন্তু বেঁচে যেতে পারতো। প্লিজ এটার দিকে একটু খেয়াল রাখবেন আমার মনে হয়। আর একটা জিনিস বলা হলো যে উই অল দ্য টাইম টক অ্যাবাউট ড্রাগস অ্যান্ড ডিভাইস। একটা জিনিস কিন্তু অ্যানিসিলিয়ারি ট্রিটমেন্ট, যেমন স্লিপ অ্যাপনিয়া, তারপর আমরা জানি যে আয়রন থেরাপি, এগুলো কিন্তু খুব ইম্পর্টেন্ট। even if you treat a patient with anti-anxiety drug, এগুলো কিন্তু খুব কাজ করে, সত্যি কাজ করে। ইন্টিগ্রেটেড হার্ট ফেইলিওর কেয়ারের হয়তো কনসেপ্টটা আমাদের আসছে, আমাদের কিন্তু এটা প্র্যাকটিসের মধ্যে নিয়ে আসতে হবে। আর এখন তো বলাই হচ্ছে যে ডিভাইস পেসিং বিয়ন্ড হার্টের বাইরে পেসিংয়ের কথা বলা হচ্ছে। মানে হচ্ছে যে স্লিপ অ্যাপনিয়ার জন্য ডায়াফ্রামকে পেসিং করে সেই ডিভাইসকে কথা বলা হচ্ছে ব্যারোরিসেপ্টরকে ম্যানিপুলেট করা। মেনি ডিভাইস উইল কাম ইন ফিউচার, বাট right at this moment, the need of the time is possibly to save those patients with acute heart failure who needs the device. আমি এটা বলে আজকের শেষ করতে যাচ্ছি। Thank you very much.
Thank you, sir, and thank you all the audience for participating in this session. Thank you all.